So, welcome to this session on shoulder joint. Okay, shoulder joint is very similar to hip joint in the sense that it is a first we talk about the introduction, that it is similar to hip joint, but it is more mobile. It is more mobile and less stable. And compared to this hip joint is less mobile but more stable, because hip joint has to be stable because it is needed for walking. Okay. The first point we write in each of this is type of joint. And this is a ball and socket type of joint of synovial variety. Ball and socket type of joint of synovial variety. So it's a ball and socket type of joint of synovial variety. The next, so first thing we write is introduction, then we write type of joint, and then we talk about articular surfaces. Articular surfaces, when we write articular surfaces, we always write what articular surface is on the medial side and what is there on the lateral side. Not always it is medial and lateral, sometimes it is superior, inferior also. Sometimes it is superomedial, inferolateral also. So here on the medial side is glenoid cavity of scapula, and on the lateral side is the head of the humerus. Now, if you see the anatomy, if you see the anatomy of this region, the glenoid is not actually, we feel it is so deep, but actually it is only like this. It is only like this. Okay. And the glenoid cavity is only like this, and it is very shallow. The glenoid cavity is very shallow. And the head of the humerus is like this. The head of the humerus is like this, huge. So it actually doesn't fit completely. It actually doesn't fit completely into the cavity of the glenoid, and that's why the cavity of the glenoid is made deep. It is made deep by a labrum. So suppose this is the glenoid. This is the glenoid. Then it is made more deep by a surrounding labrum called as glenoidal labrum. Okay, it is made more deep by the glenoidal labrum. Also, on the top, we know that in the scapula here is anteriorly is the coracoid process and posteriorly is acromion process, the spine and acromion. So there is a coracoacromial ligament, coracoacromial arch. So if this is the head of the humerus, anteriorly is coracoid process, posteriorly is acromion, and running from coracoid process to acromion is a coracoacromial ligament, and this is called as coracoacromial arch. This is called as coracoacromial arch. This coracoacromial arch serves as a secondary socket, again, so that the joint does not slip. And here there is a bursa below. Here there is a bursa, and this bursa is also there, the subacromial bursa, which also prevents the friction. Okay. Also, we know that there is the subscapularis muscle anteriorly and supraspinatus muscle superiorly, and teres minor, infraspinatus and teres minor on the sides. So their tendons fuse with the capsular ligament, and they together form what is called as the musculotendinous cuff or the rotator cuff. So these three factors, rotator cuff, glenoidal labrum, coracoacromial arch, they try to give the stability to the shoulder joint because glenoid is very shallow. But then still inferiorly, on the inferior aspect, the joint still remains quite unstable. Okay. Now moving to the ligaments of the joint. Ligaments of the joint, always the first thing that comes in that is capsule. And then thickenings of the capsule are some ligaments, and then capsules and other ligaments. So always capsule comes first. Okay, the joint capsule. The joint capsule for the shoulder joint, which will come first. Okay, and this is very loose. It has to be loose because if it is tight, then our shoulder will not move. Okay, and it is attached. It is attached anteriorly, posteriorly, superiorly, inferiorly. It is attached lower down to the neck. Okay, so dislocations can damage the axillary nerve, which is below. So the capsule is attached medially to the margins of the glenoidal labrum. Margins of the glenoidal labrum and the supraglenoid tubercle, and laterally it is attached to the anatomical neck of humerus. Laterally it is attached to the anatomical neck of humerus. Okay, except for inferiorly. Inferiorly it extends little down. Okay, to the surgical neck of the humerus. What is anatomical neck? What is surgical neck? You will understand that when we talk about the humerus, there are these trochanters, greater, lesser. So here is the anatomical neck, and lower down here is the surgical neck. Okay, so anatomical neck is here. So anatomical neck, the capsule is attached, but inferiorly it extends up to the surgical neck of the humerus. Now uh, on this capsule, there are some thickenings. Now suppose this is the glenoid over here, and this is the humerus. So capsule is there attached like this. And there are three thickenings anteriorly in the capsule. Okay. These are called as superior, middle, and inferior. Superior, middle, and inferior glenohumeral ligaments. Superior, middle, and inferior glenohumeral. Okay. So that is about the capsule. Capsule attached medially to the margins of glenoidal labrum, lateral to the anatomical neck, inferiorly to the surgical neck. And there are three ligaments, the glenohumeral ligament, superior, middle, and inferior. The second is coracohumeral ligament. Now this coracohumeral ligament, it will run something like this. So this is the scapula, this is the glenoid cavity laterally, here is the humerus, and here is the coracoid process. Okay. So it runs from the root of the coracoid process to the neck of the humerus. It runs something like this. Root of the coracoid process. From tip of the coracoid process, we have seen that the bicep brachii, coracobrachialis, the short head of biceps and coracobrachialis, they take origin. So from the root of the, and here on the coracoid process, pectoralis minor is inserted. But from the root of the coracoid process, So there are three things attached to the coracoid process: at the tip, coracobrachialis and short head of biceps brachii. On the coracoid process pectoralis, minor muscle, and at the root is the coracohumeral ligament, okay, which runs uh, from there to the neck of the humerus, okay, near the greater tuber. Okay. Then the third one is transverse humeral ligament. Transverse humeral ligament. What is transverse humeral ligament? All of us know that from the supraglenoid tubercle, the biceps brachii takes origin and it goes like this. It goes like this. Okay. This transverse humeral ligament, okay. So as the biceps brachii is actually passing like this, it runs from the greater to lesser tubercle, and it kind of plasters the mm, biceps brachii tendon, okay, in such a way that the head of the humerus gets support on the superior aspect. So the head of the biceps brachii tendon is going down like this, and this is the head of the humerus. So there is a transverse humeral ligament running like this. Okay, that gives stability to the joint. And the fourth one is the glenoidal labrum. Glenoidal labrum. This is the glenoid, and the glenoidal labrum is attached around. It is attached around the glenoid. It is made up of fibrocartilage. It is made up of fibrocartilage. Okay. So these are this is how you write the ligaments of the joint. The capsule medially attached to glenoidal labrum, laterally to anatomical neck, inferiorly to surgical neck. There are three reinforcements: superior, middle, and inferior glenohumeral ligament. Coracohumeral ligament running from the root of the coracoid process to the neck of the humerus. Transverse humeral ligament is running between the lesser and the greater tubercle, plastering the uh, long uh, tendon of the long head of the biceps, the origin. This tendon passes through the capsule. It passes through the capsule. So long head of biceps brachii and plastering it over the humerus so that the joint gets stability. And last is glenoidal labrum, which is made up of fibrocartilage. It's a rim which covers the margins of the glenoidal cavity, and it increases the depth. It increases the depth. Okay. Then there are some important bursae in relation to the shoulder joint. And the most important amongst them is the subacromial bursa. I already told you this is the coracoid process, and this is the acromial process. Here is the subacromial bursa. Okay, subacromial bursa. Okay. Then there is the subscapularis bursa. It communicates with the joint cavity. Now, why I am mentioning that it communicates with the joint cavity? Because this bursa, if it gets infected, the joint will also get infected. It communicates with the joint cavity. Okay, then there is infraspinatus bursa, and many other bursae are there. Bursa deep prolonged of triceps, latissimus dorsi. Okay, so infraspinatus bursa is also there. But this is important, and this is most important. This subacromial bursa, if it gets inflamed, the movements of the shoulder, because head of the humerus will be just below here. So movements of the shoulder joint, especially the overhead abduction, all becomes painful. Infraspinatus bursa. Bursa. What is a bursa? Bursa is just something like a synovial membrane, and there is a fluid inside it, and it is there to prevent friction. So here is a coracoacromial arch, and here is the head of the humerus. So it will again and again rub against this arch. So in between we put a bursa. Okay. So in between there is a bursa to reduce friction. So bursa is made up of synovial membrane, and It's just made up of membrane and there is fluid inside. It is placed at places where there is a muscle running in close contact with a bone or a joint to reduce the friction. That's the aim, to reduce the friction. But if the bursa, because of again and again repeated friction, gets inflamed, then the movements become painful. Okay. Now the relations of the shoulder. The relations of the shoulder joint, if we see, this is the glenoid, right? And suppose this is the anterior side and this is the posterior side. Okay, anterior side, posterior side, superior side. Inferiorly, all of us know that, and of course the glenoidal labrum and all. So inferiorly, all of us know that there is triceps. Also inferiorly is there is major. There is major. And there are the circumflex humeral vessels. Then anteriorly is the subscapularis. Subscapularis. Anteriorly is subscapularis. Superiorly is supraspinatus. So this is supraspinatus. Then there is infraspinatus. And here there is the teres minor. So teres major is here, teres minor is here. And going on, covering all of them almost, is posterior fibers of deltoid. Okay, then there is acromion. Then there is the coracoacromial arch. This is coracoid process. This is coracoacromial arch. So this is deltoid. This is coracoacromial arch. Okay. And then attached to the coracoid, all of us know, is pectoralis minor. Okay. And the deltoid is also there here, anterior. So deltoid is anteriorly, deltoid is posteriorly, almost covering the joint. And here is pectoralis major. So what all there anteriorly? Deltoid, pectoralis major, pectoralis minor, subscapularis. What is there superiorly? Coracoacromial arch, supraspinatus. What is there posteriorly? Posterior fibers of deltoid, infraspinatus, teres minor. What is there inferiorly? Triceps, long head, teres minor. Okay. And going around the neck are the anterior and posterior circumflex vessels. So that's about the relations. That's about the relations of the joint. Okay. Now, what about the blood supply? The blood supply is by anterior circumflex humeral artery and posterior circumflex humeral artery. Okay, both of them are branches of axillary artery. Anterior circumflex humeral artery and posterior circumflex humeral artery, both of them are branches of axillary artery. Then there is suprascapular artery. Suprascapular artery. You can say, when we say blood supply, you can either write as arterial supply as artery, so suprascapular artery and subscapular vessels. Now, subscapular artery. So everywhere there is a corresponding vein also. So sometimes the books will say anterior circumflex humeral vessels, posterior circumflex humeral vessels. So that completes blood supply always includes arterial supply plus venous drainage. So when you have to write it together, we write by saying anterior circumflex humeral vessels, posterior circumflex humeral vessels. Otherwise, what we do is we write anterior circumflex humeral artery, posterior circumflex humeral artery, suprascapular artery. Then we write venous drainage, anterior circumflex humeral vein, posterior circumflex humeral. It's upon us how to write. Okay. Now nerve supply. Nerve supply will be axillary nerve, the main nerve supply, because the deltoid, it supplies the deltoid. Deltoid moves this joint, causes abduction, it causes flexion, it causes medial rotation, posterior fibers cause lateral rotation, extension. So axillary nerve is the main nerve. Apart from that, musculocutaneous nerve and suprascapular nerve, musculocutaneous nerve and suprascapular nerve. Now the movements of the joint. Movements of the joint. Okay. So before I summarize that what movements are caused by which joint, I would like to show it to you. I would like to show it to you that how these movements are caused. Okay. So this is my shoulder joint. So the flexion of the shoulder joint, is like this. This is flexion. Why like this? An extension is like this. Why not like this? And there is a reason for that. Why it is not like this? Because the scapula is like this. Scapulae, both scapulae are not exactly, don't think that the scapulae, both sides scapulae are like this. The scapulae, both scapulae are slightly like this. Okay. So when the scapula is not exactly in 90-degree plane, it is slightly like this. So the glenoid will be also like this. So this side glenoid will be like this side glenoid will be like this. So humerus will be here. So therefore abduction will be like this, not like this. Not exactly abduction, adduction. It will be slightly going front because scapula or glenoid is facing like this, somewhere between the two directions. So abduction has to be shown like this, the way Statue of Liberty is abduction, adduction. It cannot be shown like this. Okay, this is also abduction only, but ideally when told in exam, we show flexion like this, extension like this, abduction like this, adduction like this. And medial rotation, when we are told to do, we may do like this, but when we do it like this, the pronation supination gets added. To minus the pronation and supination, what we do is we flex the elbow, show medial rotation like this and lateral rotation like this. Medial rotation like this, lateral rotation like this. And then there is the seventh action called circumduction. It is the combination of all the movements. Combination of all movements is circumduction. Okay. So now which are the muscles causing flexion? Anterior fibers of deltoid. And then there is the short head of biceps. Okay. And there is clavicle head, clavicular fibers of pectoralis major. They will cause flexion. Which fibers will cause extension? Posterior fibers of deltoid and latissimus dorsi. Okay. Flexion, extension. Which fibers will...
having trouble connecting. I'll keep trying.
Which are the fibers which cause adduction? Adduction is caused by pectoralis major. Okay, it is also caused by latissimus dorsi. Abduction is caused by the supraspinatus. It is also caused by deltoid up to 90 degree. Beyond 90 degree, what happens is that the scapula, it starts moving like this, because now beyond 90 degree overhead abduction, this is called overhead abduction. In overhead abduction, the humerus will go down from here. So what happens is the scapula also moves up, becomes like this, so that the humerus doesn't slip. This is called as overhead abduction. Yeah, abduction is caused mainly by supraspinatus and it is caused by biceps brachii. And in overhead abduction, for their muscles causing forward rotation, that is the serratus anterior muscle, the and upper and lower fibers of trapezius, they will help. I will show you how they help in forward rotation. Medial rotation is caused by pectoralis major. Okay, it is also caused by latissimus dorsi, by teres major. The lady between two majors, all these three muscles will cause medial rotation. Lateral rotation will be caused by muscles which are there on the back side. Muscles on the back side, they are the infraspinatus and teres minor. These are the muscles which will cause the lateral rotation. Now, let us write this into a tabular form. Now we are describing the movements of the joint. The movements of the joint always has to be written as the movement. Okay. In here it is very difficult to define the axis. Otherwise, we'll talk about the axis. The muscles producing the movement, the main muscles and the accessory muscles. Which are the accessory muscles? Okay, accessory muscles. So when we talk about flexion of the shoulder joint, the main muscle, the muscle is clavicular head of pectoralis major. Okay, and anterior fibers of deltoid. Anterior fibers of deltoid. There is coracobrachialis muscle also. There is short head of biceps also. Short head of biceps brachii. Extension. Extension is brought about mainly by posterior fibers of deltoid, and it is also brought about by latissimus dorsi. Other muscles helping in extension are teres major, okay, sternocostal head of pectoralis major, sternocostal head of pectoralis major, long head of triceps also may help, but triceps mainly causes extension at the elbow joint. Okay, adduction. Adduction is brought about by pectoralis major, latissimus dorsi. Okay, the short head of biceps, short head of biceps brachii, long head of triceps, and teres major. One thing you have started noticing that the uh, extension is caused by pectoralis major, teres major, latissimus dorsi. We said their attachment is lady between two majors, between the pectoralis major and the teres major is latissimus dorsi. So their actions are also similar. So in extension, we see these three muscles: latissimus dorsi, teres major, pectoralis. In adduction, we see again latissimus dorsi, pectoralis major, teres major. Okay. Abduction. Abduction mainly deltoid, then supraspinatus. Okay. Then serratus anterior and upper and lower fibers of trapezius. So these two help in forward rotation of scapula. So the scapula moves forward in overhead abduction. So they morely help in overhead abduction. Medial rotation is caused by pectoralis major. So once we write pectoralis major, there comes latissimus dorsi, there comes teres major. That's how we remember. Okay. Lateral rotation is caused by posterior fibers of deltoid and the posterior muscles, infraspinatus and teres minor. Infraspinatus and teres. So actually this chart is there in your textbook also. So why do you need a teacher? You need a teacher to tell you that extension, adduction, medial rotation.
I'm having trouble connecting. I'll keep trying.
These three actions are brought about by latissimus dorsi, pectoralis major, teres. Okay. So now going to the last part, of the uh, joint, and that is the clinical anatomy of it. And before the clinical anatomy of the joint, I just wanted to talk about one more thing, and that is the overhead abduction. Overhead abduction of shoulder joint. So normally people used to previously say that 0 to 15 is by supraspinatus. Nowadays this thought process has gone, and they say 0 to 90 is by deltoid and supraspinatus. Now at 90 degree, what happens is, this is glenoid. and here is the acromion of acromion. So at 90 degree, the humerus at 90 degree, humerus hits the acromion, hits the acromion, and so further movement becomes difficult. Okay, the greater tubercle hits the acromion. So then at 90 degrees, there is lateral rotation brought about by infraspinatus, and there is minor brought about by infraspinatus and teres. So there is lateral rotation, and further 30-degree rotation becomes possible. Further 30-degree rotation becomes possible, and so now we reach up to 120 degrees. Now 120, further 30 degree of abduction becomes possible, and now we reach up to abduction of at 120 degrees. Now at 120 degrees, what happens? There is forward rotation of scapula. Okay, so scapula, which was standing like this in its position, and humerus is now at 120 degree. Now, if humerus goes further like this, it may slip down. So what happens is the scapula now becomes, instead of it from this position, it goes to forward rotation. And so further 30 degree becomes possible. And now we have reached up to an overhead abduction of 150 degrees. So 0 to 90 was brought about by deltoid. At 90 degrees, the greater tubercle was hitting the acromion. So there was lateral rotation of the humerus. So further 30 degree became possible, and we reached up to 120 degree. At 120 degrees, the forward rotation of scapula started, because if we would have been abducting more, the humerus would have slipped down. So forward rotation is brought about by the upper and lower fibers of trapezius and serratus anterior muscle. And further 30 degree becomes possible. Okay, so now scapula has moved like this. So when scapula moves like this, there is coracoid process over here, and then there is clavicle here, and there is a ligament between the two. There is a ligament between the clavicle and the coracoid process called as coracoclavicular ligament. Now this ligament gets stretched because now scapula has moved forward. So now what happens is the clavicle, to relax this ligament, rotate some, that is called as linear rotation of clavicle. There is a linear rotation of clavicle which happens at 150 degrees, and then this ligament is relaxed, and then is further 30 degree of uh, forward rotation possible, and that's how we reach up to 150 plus 30 degree more, 180 degree of abduction takes place. Again, I'll repeat, little difficult to understand. Previously, people used to say that 0 to 15 degrees by supraspinatus, and but now they say that 0 to 90 is both by deltoid and supraspinatus. So 0 to 90 very smoothly happens, but at 90 degree greater tubercle hits the acromion. So there is a lateral rotation of the humerus brought about by infraspinatus and teres minor. This lateral rotation allows 30 degree more abduction, and then we reach up to 120 degree of abduction. After that, beyond 120 degree, if the humerus further goes up, it may slip down. So instead of humerus going up, now humerus also goes up and scapula moves forward. So there is forward rotation of the scapula brought about by serratus anterior and upper and lower fibers of trapezius. So when this happens, further 30 degree is possible. Because of this forward rotation, we reach up to 120. But at 120 degrees, this coracoclavicular ligament gets stretched. So scapula cannot do forward rotation further. So the clavicle undergoes a linear rotation to relax this ligament. Once this ligament is relaxed, further 30 degree forward rotation becomes possible, and the humerus also moves up. That's how we reach up to 180 degree of forward rotation of scapula. So now we are going to the last part of the uh, we are moving to the last part, that is the clinical anatomy of the shoulder joint. And the first point is dislocation. And we have discussed again and again, it's the inferior dislocation, which is very common. This can damage the axillary, which is around the surgical neck. Okay. There is something called as optimum attitude of the optimum attitude of the joint. That means sometimes the joint is fixed in this position, and that is 45 to 90 degrees. But if that means if a patient joint is become very painful and he cannot move it, so they fix it at a 45-degree by putting a screw. The to prevent the further pain, because joint has to be at 45. When I'm writing right now, my joint is at 45. When I'm eating, my joint is at 45 degree. No, hardly we keep the joint so much adducted. So this is called as the optimum position of the joint. Okay. The third is shoulder tip pain. What is shoulder tip pain? The shoulder and the shoulder receives the shoulder tip receives nerve supply from the C2, C3 cervical segments, and they also give rise to phrenic nerve which supplies the diaphragm. So if there is any irritation of the diaphragm, the pain will be referred to shoulder, and we may keep on investigating what is happening to the shoulder, but nothing is happening to the shoulder. There is some pathology below the diaphragm, and because diaphragm is supplied by phrenic also has C2 C3 as root value, shoulder tip also has C2 C3 as root value. So the pain below the diaphragm may be referred to the shoulder tip. Okay, there is something called as a frozen shoulder. So frozen shoulder happens in patients between 40 to 60-year-old. They complain of stiffness. They complain of stiffness of the joint, and this stiffness is because of the synovial membrane getting inflamed. Okay, when the synovial membrane of the uh, patient becomes at synovial membranes, the two layers become adherent to each other, a person develops stiffness, and that is called as frozen shoulder. Just physiotherapy is useful for this. Then there is something called as a painful arch syndrome. Painful arch syndrome. So during the overhead abduction, between 30 degrees to 120 degrees, or maybe between 90 to 1, suddenly there is a painful movement. Okay, this happens due to subacromial bursa inflammation. This happens due to any broken bone pieces in the joint. Okay, that is called as a painful arch syndrome. Okay, so frozen shoulder dislocation. The most common thing is the dislocation, which is inferior and axillary nerve getting damaged. So that's all about the shoulder joint, which was, I'll go through a very fast revision of the shoulder joint for all of you. The shoulder joint is a ball and socket type of a joint of synovial variety. Medial is glenoid cavity, lateral is humerus, and it is made more stable by the rotator cuff, by the glenoidal labrum and coracoacromial arch. It has a capsule. Capsule is very loose. It is attached to the glenoidal labrum, laterally to anatomical neck, inferiorly to surgical neck, and it has superior, middle, and inferior crinohumeral ligaments. There is coracohumeral ligament which runs from the base of the coracoid process to the neck of the humerus. Okay, then there is the transverse humeral ligament which runs over the biceps brachii from greater tubercle to lesser tubercle, and then there is glenoidal labrum, which is made up of fiber cartilage, which deepens the glenoidal cavity. There are bursae, subacromial bursa is the main, subscapular bursa communicates with the joint cavity, and infraspinatus bursa. Then there are relations. There is deltoid, anteriorly anteriorly subscapulary, superiorly supraspinatus, posteriorly infraspinatus teres minor. Deltoid is there posteriorly as well as anteriorly. Superiorly is coracoacromial arch, inferiorly is triceps and teres major. The blood supply is by the anterior circumflex and posterior circumflex humeral, suprascapular vessels and subscapular vessels. Nerve supply is mainly by the axillary nerve, musculocutaneous nerve and suprascapular nerve. The movements are flexion, extension, adduction, abduction, medial rotation, lateral rotation, of which extension, adduction, medial rotation brought about by latissimus dorsi, teres major and the pectoralis major. Okay. Overhead abduction 0 to 180, up to 90 happens fine. At 90, retrotubercle hits the acromion, so there is lateral rotation. Further 30-degree rotation happens. Then there is forward rotation of scapula. Further 30 degree up to 120. Then this ligament, coracoacromial ligament, co-clavicular ligament gets stretched. So linear rotation of the clavicle happens for further 30 degree, and that's how 180 degree abduction is complete. Clinical anatomy dislocation is very common, and axillary nerve can be damaged. 45 to 90 degrees, the optimum position. Shoulder tip pain, because phrenic nerve which supplies the abdomen diaphragm is also the same, has the same root value of the shoulder of as the nerve supplying the shoulder tip. Frozen shoulder, there is stiffness due to the two membranes of synovial membrane layers getting adherent to each other, and painful arch syndrome. With that, we stop our session on the shoulder joint. Thank you so much.